Okay, everyone, thanks again for joining us on this webinar on low burden tobacco cessation strategies and strategic partnerships. My name is Jim Pavlik, and I am the program and policy analyst at the Behavioral Health and Wellness Program at the University of Colorado Anschutz Medical Campus. In my capacity here at BHWP, as most of you probably know by now, my work is in assisting organizations to adapt their workflows for a variety of quality improvement initiatives, mostly focusing on chronic disease prevention and control, and with a particular emphasis in tobacco cessation interventions, which is to say, the actual topic of today's webinar. Just a quick note that neither I nor BHWP in general has any conflicts of interest to disclose in regard to the content of today's presentation. Today's learning objective is simple, to highlight several actions that you can take to move your organization in the direction of providing a comprehensive suite of effective, efficient tobacco cessation interventions, ideally with the resources that you currently have. And to do that, I will have to define what we mean by low burden. I will have to list and describe at least some of those actions that you can take, and I'll provide some resources to guide you as you adapt the best practices defined today to meet the specific needs of your organization, your community partners, and the populations that you serve. Before getting too far along, I do want to address this the term sustainable. Typically in a presentation like the one that we're going to have today, we would talk about scalability and sustainability. And one point that I always like to make in general is that in general, scalable initiatives are also sustainable, but not necessarily the other way around. So of the two, being sustainable is the more important. And I'm essentially using the terms low burden and sustainable as rough synonyms. The former emphasizes the impact on your staff today, and the latter emphasizes the feasibility of maintaining these improvements over longer time horizons. In my experience, changes perceived as low burden today are much more likely to become sustainable over the long haul. So by low burden, we mean primarily two things: one economic and one psychological. Number one, the benefits that are delivered are worth the costs incurred to deliver them. And number two, those benefits are understood and appreciated by those who perform the services. So on number one, in a narrow sense, we could be talking about ROI, the return on investment. If we determine that a project costs an additional $100 per client, but saves the organization $200 per client, we'd say that that project is worth doing. But we may consider it worth doing even if the ROI were significantly narrower, provided that the project serves some other purpose important to the organization, like fulfilling our mission to care for our community, for example. On number two, we're primarily talking about system-wide culture. Many tasks have been forced on employees over time, over the last 20 years or so. Caregivers spend anywhere between 40 and 70% of their day doing administrative work instead of providing care. No action, program, suite of services will ever be considered sustainable if the staff are actively pushing back against performing those functions. Which is all to say that we define low burden initiatives as those that satisfy at least the first criteria, and which are housed within a robust policy regime that aids in the satisfaction of the second. One thing I would like to note here is that this entire two-part community of practice, with twin emphases on developing capacity within both local public health and within community-based partners, is itself an important component of designing low-burden strategies that satisfies this second element of sustainability, this idea of embedding it within formalized, standardized policies, protocols, etc. We have spent nearly 2 full years discussing the concept of the 5 A's and how they can be used to conceptualize workflows within an organization and how they can act as the basis for a needs assessment of an entire community, which can then be used to help design programs that are responsive to those gaps. Seeing yourself as just one element of within a system that provides robust tobacco cessation services is an important step in making sure you're providing those elements of the 5 A's where you can excel and deferring to others when they might be better, if others exist to fill those roles. So as you continue to design and improve your suite of services, try to consider today's conversation within the context of all those webinars that have preceded it. They really do work best when considered as an integrated way to approach systemic programming. So to satisfy criteria 1 of sustainability, an intervention must work. It must convey some benefits to the staff directly, but more importantly, to the client. A tobacco cessation intervention must successfully get people to quit tobacco. So which interventions work? And to know that, we have to understand some things about quit attempts in general and where we can impact them. So I want to share some back of the envelope calculations. And at first I want to say what I mean by that. The numbers that you're about to see are approximations. They take a lot of things for granted. They have not been vetted by an epidemiologist. To emphasize the lack of precision here, I've done a lot of rounding down to show more conservative figures. I also chose the lower and upper bounds of certain estimate ranges selectively to favor conservatism. This is because my goal here is not to exaggerate what is possible, but I'm also not doing this to offer actual projections that might be truly achievable. I'm doing this merely as an exercise to build some intuition around the scale of our potential impact and for whom our efforts will be most impactful. So we begin with about 800,000 adult smokers in Arizona. And about 75% of tobacco users report they want to quit within the upcoming year. So now these figures are for adults only. So it's worth mentioning that most individuals younger than 18, when they're asked if they imagine themselves to be a smoker at the age of 30, most of them say they don't. In fact, by the time tobacco users reach the age of 18, 50% of them have reported having already tried to quit and failed. But going back to our adults, when we ask them if they went one day in the past 12 months with the intention of, if they went 24 hours without smoking with the intent of being quit, only about 65% of them report that they did. The group represented by that gap between those who say they want to quit within the next year, but then actually tried in the previous year, that leaves us about 80,000 folks with a 0% abstinence rate at the end of the year because they didn't even try. A group that if we could reach them all and persuade them all to use counseling and medication, that could result in about 24,000 additional quits. I want to take a pause right now before going on to consider who and what we're talking about here. Most presentations begin with some sort of argument, an appeal to why are we talking about this? I didn't do that today because you're all members of this community of practice. So I think that we're all on board with a general idea that helping our clients to quit tobacco is a good idea. Nevertheless, there are some common misconceptions that I feel compelled to address. And this is the moment where they become relevant because I'm tossing around numbers like how many people want to quit and what their success rates are if they try. It's worth figuring out if the criminal justice involved population may be significantly different than the general population reflected in these first 3 bullets. One of the major misconceptions is that individuals in the criminal justice system smoke at higher rates out of a greater need. This greater need leads to a lower desire to quit, and the lower desire to quit is where we get our higher prevalence rates. And we do know that the criminal justice involved population does have a higher prevalence rate. It's about 5 times higher than the general population. So this pathway seems superficially plausible. So it's worth stepping back to consider, do these individuals want to quit at lower rates than the general population? And what impact does their condition have on their ability to quit? Whoa, whoa, whoa. There we go. Sorry about that. It is indeed the case that incarcerated individuals or those at risk of incarceration share certain inputs and outcomes with other health disparities groups. Among them are poverty as children and lower educational attainment as adults. And these factors combine to create lower incomes, higher chronic stress, and others. It is also the case that tobacco use contributes to, and aggravates various conditions. It primes the brain, for example, to future addictions. It can increase pain sensitivity and increase the power of certain opioid effects. It can dampen the power of various therapeutic drugs, including certain painkillers like acetaminophen. But it is also the case that the tobacco industry is aware of these associations too, and they have deliberately marketed their products to individuals with certain risk factors, thus driving up prevalence rates. And this is the first clue that the superficial theory previously presented might be false. It could be the case that these populations would have higher prevalence rates even without the influence of the tobacco industry marketing to them. But clearly the tobacco industry itself disagrees, or it wouldn't spend so much money marketing to them. It's pretty clear to see how the tobacco industry targets racial and ethnic minorities, how they tailor their messages for different sexes or sexual orientations. It isn't quite as upfront, not quite as transparent, not quite as clear how they target the incarcerated. There aren't billboards up inside prisons, for example. I don't know that the tobacco companies have an explicit interest in activating or exacerbating use in jails and prisons, but this is the consequence of their focus on low-income individuals with high risk factors. Seen here as just one example is a map showing how tobacco marketing is more dense in areas within a specific radius of WIC clinics, women, infant, and children clinics. Another area of overlap that drives the prevalence rates inside jails and prisons is due to higher use among individuals with behavioral health conditions. Not only is the prevalence rate in such populations higher than the general population, they also smoke more. This means more instances of chronic disease, more money being spent, more time out of the day being used up with this addiction. Contrary to the common belief, since the consequences of smoking are higher in this population, that is why I want to stress that, since the consequences of smoking are higher in this population, while the prevalence rates are higher, the need and desire to quit are also higher. So to correct our misconception, what we see is that individuals in low-income neighborhoods or from other marginalized groups are more likely to lack access to genuine therapeutic services, and thus may be more attracted to smoking as a mode of self-medication or as a coping strategy. This drives up the potential for use. This vulnerability attracts the interest of the tobacco industry, which increases its outreach to this population, which further drives up use, both the numbers that use and the amount that each uses. This increases the financial and physical toll of tobacco, which increases the desire to quit. But it also increases dependency, thus making it more difficult to quit without access to resources, which, as we've already pointed out, they don't have. And this is how we get our higher prevalence rates. And just to summarize and recap this point, because it's really, really important. The first slide with an arrow, the one that looks like this but says something different, the first slide with the arrow implies that the use is higher because the desire to quit is lower. But this doesn't correspond to what we observe in reality. In the real world, we see the same or higher interest to quit, just lower success in quitting. And that's where we come in. Several years ago, BHWP had the opportunity to collect a convenient sample of over 600 individuals in substance abuse treatment facilities across Florida. We asked those individuals whether they were current tobacco users, whether they were ex or non-users, and if they were current users, whether they wanted to quit within the next 2 months or perhaps never. Here are the results that we found after selecting for just those individuals who were inside of court or part of a court-ordered program. And about 17% of those folks were ex or non-smokers at the time we interviewed them. Of the smokers, 65% of them said they wanted to quit within the next 60 days. This is roughly correspondent to that 75% within the next year figure. Maybe a little lower, it's hard to say, they're not exactly asking the same question in the same way, but 65% in the next 2 months versus 75% in the next year, you can see that those numbers are actually pretty close to one another. So, with all that in mind, let's return to this previous point. So we have group A, that's represented by this 10% gap between the 75% who want to try and the 65% who actually do try. This was going to give us those 24,000 additional quits. Excuse me. So what about the 520,000 people who do make a quit attempt? What happens to them? What do they do? What does their success look like? Well, of those, most of those quit attempts will be made without any help at all. We used to say 95% of quit attempts were made with no help at all. But with the rising popularity of quit lines, the known safety and relative affordability of nicotine replacement therapy, growing internet connectivity, et cetera, more and more people are availing themselves of some assistance. So I'm just using a 60% figure here. It's just more conservative than 95 by about a third. These numbers vary widely across states. I don't happen to have Arizona's figures, but in any case, out of the 60%, only about 7% of them are going to actually still be quit 12 months later. That leads us to Group B, a group of about conservatively 312,000 Arizonans each year. And of that group, about 21,840 will successfully quit on their own. If we could have persuaded all of them to use counseling and pharmacotherapy, there'd be an additional 56,000 successful quit attempts from this group every year. So here's where I'm getting some of these numbers. And this is from Fiore et al., 2008, a reference I've mentioned before. And you'll see that I used 7%, the high end of unaided, to illustrate the unaided quit attempt. And I used about 25%, the low end of our best case scenario, to sort of generate these numbers. That's what I mean by saying I was using conservative figures. And I did this deliberately, so to make it clear that I was not trying to exaggerate what the potential here was. And this leads us to Group C. Group C is the collection of individuals who will seek out an evidence-based best practice, but without the right supports will demonstrate success at the lower end of this range, the 25% side. That is, someone may seek out NRT and counseling, but if they also sought our support, adding our guidance and instruction to their toolbox, instead of the 25% chance I gave them, they might have seen a 30% chance of success. The bottom line is that the evidence base suggests that the best thing a tobacco user can do is get access to tobacco cessation counseling and combination nicotine replacement therapy, or varenicline. All of our concrete actions are designed to impact groups A, B, and C, which is to say we want to, 1, reach those individuals, 2, convince them to trust us, 3, encourage them to avail themselves of the highest intervention they need, which is ideally counseling and medication, and 4, provide them those things if we can. So what are we going to do? We're going to use the 5 A's to implement and deliver the tobacco cessation recommendations of the United States Preventative Services Task Force. And if that name sounds familiar, it may be because anything with a grade of A or B from the United States Preventative Services Task Force must be a reimbursable service for the insurance policy that's paying to be considered compliant to the Affordable Care Act's Essential Health Benefits section. And all of the ones that I'm about to list have an A, not a B, an A. And those services are specifically telephonic counseling, group support, individual counseling, peer support, and medication-assisted treatment. Because, of course, some of you may be more familiar with the Ask, Advise, and Refer, and even more of you may be even more familiar with screening, brief intervention, and referral to treatment, SBIRT. They're all sort of interchangeable, but just because of what I just did, I showed the screening, brief intervention, and referral to treatment sort of take the place of Ask, Advise, and Refer. That's often how these two things are taught, that SBIRT and the 2 A's and an R are the same thing, but in reality, that's not quite the case. The screening section, or the brief intervention section of SBIRT, is actually sort of a combination. It pulls a little bit from the assess and assist pieces of the 5 A's, which makes SBIRT actually more like the 5 A's than the 2 A's and an R. And I just want to emphasize that if we're making good referrals, part of a good referral is closing the loop and following up with either the client themselves about how that referral is going, or if you have a really robust partnership with that referral source, then following up directly with them. So now that we're in our second section on planning, you might be wondering if we're ever going to get to doing stuff. Well, we will, I promise. So it's worth pointing out at this time that planning well, which is why we're spending so much time here, planning well, while itself not an activity that generates revenue, it doesn't reduce expenditures necessarily, it doesn't necessarily directly improve health outcomes. It's nevertheless absolutely critical. So if you remember earlier, I said that in order to satisfy the most fundamental property of sustainability, an intervention must work. Well, in study after study, one of the critical factors in determining whether a workflow adjustment or new organizational policy succeeds or fails is the time spent in planning and the effort given to creating an honest, quality course of action. And crucial to the planning process itself is accountability. Who is responsible for doing what? In the realm of tobacco cessation services and supports and policy, a crucial figure that dominates all others and the formation of which predates all the other steps is the Wellness Committee. A Wellness Committee serves as a central point of contact for the creation and dissemination of the new policy changes. It is the Wellness Committee which will serve as the main point of creativity, taking the best practices mentioned in this webinar and in other places, and modifying them to fit the needs of your client population and your staff's willingness and capacity. So for more on the Wellness Committee, like who should be on it, which is what the slide here is supposed to be representing, just download for free the Tobacco-Free Policy Toolkit from our website. You'll also find it on the Arizona Project resource site. It's filled with a variety of tools and worksheets to help guide your work in this area. If you haven't already taken a look at it, I highly encourage you to do so now. This is a prime opportunity. So unfortunately, there is a gap between no burden and low burden. And this gap is not unimportant. So one way to get more new things into a workflow is to first analyze your current workflow and get rid of the stupid stuff. In an effort to reduce unintended burdens for clinicians, leaders at a health system in Hawaii asked all employees to look at their daily documentation experience and report anything in the electronic health record that they thought was poorly designed, unnecessary, or just plain stupid. Basically, this health system allotted a certain amount of time for people to just report anything that they just thought didn't matter. Now, critically, some of these things were really poorly designed, and they were able to fix them. Some of these things were unnecessary, and they were eliminated. Some things seemed unnecessary, so the team in charge was able to explain why those steps were necessary to complete or why that information was necessary to collect. And some things were holdovers from previous eras, previous initiatives, actions that were necessary and smart once, but not any longer. In all, this system estimated they were able to eradicate thousands of hours of wasted time. Now, this example here is from a hospital system with complicated and nuanced EHRs, but when I worked in a community behavioral health center, there were some small redundancies that I noticed could have been eliminated. A rough estimate in that regard indicates I was duplicating information costing me roughly 3 minutes per note. We're not talking about like a huge heavy lift here, 3 minutes per note, but I had around 6 clients each day and I worked 5 days a week, 200 days per year. That's 60 hours wasted each year just for me. So now you multiply that by the hundreds of employees in my organization at that time, which had way more complicated notes than I did, and you start to see the potential for some real savings. More important to me than the savings, though, is the message that you're sending to the staff when you undergo this kind of process. You're saying your time is valuable. We know, understand, and appreciate that. Let's put your time where it matters most to you with your clients. Preceding system changes with this elimination of stupid stuff can also imply something about the new things you want to add. You're saying these things matter. It says we're the kind of people who value your time, so we wouldn't add anything that dilutes your ability to care. You don't have to be using an EMR, an electronic medical record, or an electronic health record, or any note-taking system for this concept to be relevant. Everybody has procedures and protocols that they have to perform in order to accomplish their daily jobs. Forms they have to fill out, people they have to CC on emails, meetings they have to attend. Part of any system committed to continuous quality improvement should be reviewing these sorts of things, analyzing them for their content and their outputs, and getting rid of the stuff that doesn't work. Eliminating stupid stuff is not an absolute requirement. Uh, Only you can know if your current systems have started to suffer from service or administrative creep. But before you embark on major alterations to workflows, you kind of need to know what you're currently doing so that you can find opportunities to enhance those processes with tobacco related additions. Before I came to BHWP, part of my assignment at Health and Human Services in DC was specifically in this area of strategic alignment, or what they call in MBA programs, if that's your bag, strategic management. I often wrestle with how best to communicate what I mean from this slide, but I heard this example recently, and I'm stealing it. I heard a respiratory therapist was talking about how she does this sort of agency alignment biz, and what she said was that she was working with a patient, and as the respiratory therapist, her primary goal was to improve her patient's lung function. Clearly, I mean that's it. That's her job. Improve the patient's lung function. And there's a lot of different ways to do that. Add exercise, different medications or whatever. The patient's primary goal was to spend more time and better time with his grandkids. And it turned out that tobacco cessation was a strategy that would achieve both of their goals. And I like this example because it makes clear the delineation between goals and strategies. I think we normally think of tobacco cessation as a goal, but what we're talking about is moving it up in the sort of the chain of goals and strategies, tactics and techniques up to the strategy level. Tobacco cessation may be someone's goal, but in a lot of cases within systems, tobacco cessation is a strategy to achieve some other goal. So when I've previously employed individuals to align their strategies with their partners' strategies, I think what people hear me saying is that we have to convince someone else to believe that their goals are our goals. And that's not what I mean at all. Different organizations have different goals. They have different missions. They have different charters. What we want to do is agree that to some varying levels of degree, incorporating tobacco cessation services is a strategy to achieve our individual, unique, and different goals. If you're on the line today from public health, then improving population level morbidity and mortality figures and maybe reducing infant deaths are potentially your goals. Promoting tobacco cessation is a strategy to achieve those goals. If you're on the line today from a jail or prison, then maybe your task is reducing recidivism or reducing the inflow of contraband or reducing preventable visits to health services or reducing maintenance costs. All of these things could have been the things that are assigned to you or you're tangentially responsible for. It turns out that getting inmates to quit smoking can aid in all those endeavors. And thus, there is a shared strategy that improves the quality of life inside the jails and prisons that also contributes to the general improvement in our key indicators of public health. So once we've agreed that adding tobacco cessation services and supports can help us achieve our larger organizational goals, then we should look at how we achieve our current goals, which is to say that pictured here is a tobacco cessation workflow that has been adapted from a common, more general clinical workflow. From a strategic alignment perspective, the ideal situation is to make the tobacco cessation workflow and the general workflow be the same workflow so that the client isn't moving in and out of different paths and so that none of our staff have to add additional tasks or perform tasks in a redundant way. Tobacco cessation services occur at the most logical time and are performed by the most logical person given whatever structures we currently have in place for these sorts of things. So while tobacco-related questions may be added to the intake form, we don't create a new role or for a person to ask just those questions, right? We train our intake person to ask them during the established intake process, and we train that person how the answers to those questions will impact the patient's routing. The point is to refer back to those evidence-based tobacco interventions and make sure that all the people who see the client are trained to provide the services that most correspond with the services that they are already doing. So other examples might be that a person who can perform a PHQ-9, that's a brief depression assessment. So the person who can perform a PHQ-9 can also do the 2-question heaviness of smoking index scale to determine nicotine dependency levels. Certified addictions counselors that a client has been assigned to for their opioid recovery can also provide counseling on nicotine dependence recovery. A psychiatrist or a psych nurse with prescribing authority who's familiar with the client's current regimen is the ideal person to recommend, explain, and monitor the nicotine replacement therapy use. The complicated workflow on this slide does not seem to convey low burden. I admit that. But in addition to the alignment possibilities already mentioned, another thing I want to point out is the distribution of the work that's reflected on this slide, on this workflow. The work I'm talking about doesn't fall on one person, and so it's experienced as a low burden task for many people rather than a high burden task for one. As I already mentioned, this is not a 5A's training, but I do want to return to this concept as it is the critical way to tailor our services in such a way as to ensure that everyone gets as much support as they need and no one gets too much. That is, I want the 5A's adopted to ensure healthcare equity and not healthcare equality. As we contemplate adding tobacco cessation services, setting the proper expectations is an important planning consideration. What do we want to do? How will this impact our work burden? What do the time and costs look like? It's important that we both provide the level of care our client needs, but not provide any more than is necessary. Additional time spent with a client that doesn't need it, additional pharmacotherapy provided to a client that doesn't need them. These are both resources that once spent cannot be spent on clients who do need them. Also, ramping up intensity on a client that doesn't require it may actually create resistance in a client that was initially willing to accept assistance. So pictured here is a sample projection of what the additional burden to the workflow might be if the population served resembled the pie chart of the drug court participants that I showed earlier. Basically, we're going to ask every single person if they use tobacco. That's 100% of them. 83% in our example are currently smoking, and they're going to receive advice to discontinue their use. So please, again, refer to other trainings in this series for a fuller walkthrough of the 5A's. 17% of everybody who walks through the door are non-users, and 29% have no interest in quitting at all. That leaves us only 54% who are going to get any level of support, perhaps a nice form, a referral to a community-based service, a referral to the Arizona Ash Line, in-house group or individual counseling, or perhaps NRT or one of the non-nicotine pharmacotherapies. The intensity of the services that you can provide will be determined by your ability to provide them, but a rough breakdown may look like the one seen here, with the highest percentage requiring the highest service you can offer and the lowest percentage receiving the bare minimum, however you define what the bare minimum is. So on the previous slide, I did mention referrals. Perhaps the single biggest takeaway from this presentation, combined with the one that we called 5A's in the health neighborhood, the very first one that we did in this second round, is that making good referrals and being a good referral is literally the central role of being a good neighbor in a health neighborhood. No matter how good your services are, no matter how many of them you offer, you will not be the right fit for every client. Identifying what their needs are and getting them to those service providers is key to getting the best results for them. This may mean investigating who those other sources are, so rely on public health to help you out in that endeavor. It may mean cultivating those relationships. It will definitely mean formalizing and ideally standardizing your referral procedures and then monitoring them for gaps and improvements. One thing to consider as we design such systems is that clients prefer as many services and products as possible to be available in the same transaction space. This is why department stores like Walmart and Target have added groceries. This is why Amazon is our most popular retailer. Similarly, it is one reason among many that integration is a driving force in our healthcare delivery sector. The more important reason is that there is no hard line between mental and physical and social health. Some mental health issues cause physical health problems and vice versa. Some co-occur because they share the same cause. So making sure that mental and medical care is provided at the same time by a team of individuals in continuous communication is essential in the treatment of a dependence as strong as nicotine causes. Which is to say that all things being equal, the more the services described above that you can provide yourself, the better off the clients are. Failing that, you want to find a source for each service that you don't provide. And ideally, you want to have a systematic link between you and those that do provide those services. And two critical things about referrals. They have to be relevant and useful to the client. A client who has informed you that they are unavailable on Wednesdays should not be referred to a group that only meets on Wednesdays. And referrals should be made enthusiastically. We all know as well as we know anything that seeking any help for tobacco cessation can at least double the chances of success for any given quit attempt. So at a minimum, the quit line, a group, a counseling session, a round of NRT, all of these things are better than nothing. So sowing doubt about the potential efficacy of these referrals undermines that success before it even begins. The final 3 points on this slide all go toward developing a robust partnership with your referral sources and those that refer to you. The more knowledgeable you are about the locations, times, personnel, and unique characteristics of your referrals, the more appropriate you can be assured they are. The more enthusiastic your recommendation can be, and the better you can be about setting proper expectations with the client about their future experience. So I do want to go back and talk a little bit about a second point that I sort of glossed over. And I want to illustrate how important this the power of positive thinking, basically, can really be in this world. A few years ago, BHWP partnered with National Jewish Health, who has several state contracts to operate quit lines. Callers to this was 6 states. Callers to 6 different states were grouped into 2 buckets. Those that said they had no mental health condition and those that said they did. And those who reported having a mental health issue were further divided into 2 buckets. Those who thought their condition would affect their outcomes negatively, and those who didn't believe that. So now in aggregate, those in the mental health bucket, that is the ones who said they had a mental health condition, did have lower success rates than those who who reported no mental health condition. But when we look at that effect versus no effect button, something really interesting comes to light, which is that between these 2 things, we see a 3%, well, what eventually becomes a 6-point gap between those individuals who, the success rates of those who did not think that their mental health condition would impact their cessation attempt. So, which is just another way of saying it's another way of saying or keeping in mind that nicotine is an extremely addictive drug. It is legal, it is normalized, and in some cases a moral activity in many of the social circles that our clients live within. And it is fully ingrained in our culture with movie characters smoking, billboards, magazine ads, et cetera, et cetera. So lapse and relapse are common. Your referral sources, no matter how good they are still going to probably have more quote unquote failures than successes on their scorecards. But in nearly every case, some intervention and support is better than nothing at all. So make that referral enthusiastically because optimism is empowering. The flip side of making good referrals is being a good referral source. I've already mentioned this. Make sure that local public health, nearby hospitals and clinics, work training programs or GED programs, courts, clerks, and judges all know which services that you provide. And while you're making those introductions to them, be sure to find out what services they provide and what needs they have. Look for areas where they're already doing some of the work so that you can back off and rely on them. Look for opportunities to formalize how shared clients can be transferred back and forth without losing information or causing it to be collected more than once. So I know that what I've said so far in this presentation seems sort of pie in the sky, theoretical. So is it like, how do you conceptualize this, or how do you prepare for that? So I promise you that I've actually mentioned some concrete things, and I'll have those listed out in a little bit more explicitly in just a minute. But for just a minute, let's get really specific. If you've already added some tobacco cessation services, what are some things you can consider adding to support or augment those services? How low burden they are will largely be determined by your current staffing capacity and budget, but nevertheless, they're worth considering. And the first thing to consider is add wellness groups. They don't have to be specifically tobacco groups, but obviously if you have that level of need and the interest to do so, you should do that too. I'm saying wellness groups because Groups focused on stress management or nutrition or sleep or whatever is a good complement to tobacco groups, or they can be a good entry into tobacco cessation for somebody who hasn't yet set that goal for themselves. So whether as a standalone precursor to a tobacco group or in a supplementary role, wellness groups can be good additions to robust tobacco cessation programming. Now, this is the thing that is the highest burden, that has the highest burden that I'm going to recommend. But if you're already running groups, if you already have individuals who run other recovery groups, this might not be any more of a burden than finding a relevant curriculum and adding it to the rotation. The second most burdensome thing I'll recommend is getting your staff trained in motivational interviewing. What's great about MI is that any level of care staff, including peers, can be trained to use it. It is applicable across behavioral change goals, including substance recovery, weight management, diabetes management, household budget-related activities, etc. So no matter what or how you're engaging with your clients or on what you're engaging with them, you can use these skills and when the time comes, apply them to encourage quit attempts and support them. Use or leverage biofeedback. We often refer to the CO monitor, the thing pictured here, as like the scale in Weight Watchers, you can't see my finger quotes, or the stethoscope of cessation. The CO monitor, this gives us a quick, non-invasive, metaphorical peek at what's happening inside the user's lungs. Carbon monoxide adjusts very quickly after cessation and improves even with modest cutting back of cigarettes per day. This is nice in a situation where the best benefits to cessation are a long time in coming, sometimes years, and are often preceded by a lot of inconveniences like withdrawal, coughing, insomnia. But monitoring carbon monoxide is not the only biofeedback option. If you're already in a setting where you are requesting and reading lab results, you may consider adding cotinine or anabasine to the drug test screen. It may even be the case that these compounds are already on the labs you're seeing with your clients. You just may need to know to look for them. In any case, it might be a very small fee to add them if they aren't already there. Two quick notes on biofeedback. The first one is, this isn't always necessary. Self-report of cessation tends to correlate pretty heavily with either carbon monoxide or drug screens. That is, if you just say, are you still smoking? Most of the time people just tell you the truth. Which is, the big exception to that is in situations where relapse is punishable. And that leads to my second point. These methods should only be used therapeutically to encourage reduction and abstinence, not as another way to discover noncompliance and punish it. And finally, to return to the conceptual stuff, do embed whatever you do within a formal, promulgated, and enforced organizational policy. The toolkit here is downloadable for free from our website. You can find it on our resources page and also on the resources page for this community of practice. Like planning, evaluating does not directly lead to a financial return on investment. However, by improving process scores and potentially outcome measures, it does help to simultaneously enforce the organizational commitment to these services and adds to an organizational culture that values wellness, learning, and improvement. So this list assumed you don't have access to internal administrative data. Instead, I'm saying go to the national, state, and county level data. National surveillance instruments like the Behavioral Risk Factor Surveillance System can tell you what your state and sometimes even your county level prevalence rates are. You can then estimate or run a report to figure out if your particular catchment area is exhibiting a greater need for services. You may also be able to figure out your state quit rates, what those are, and the success rates for various interventions. For example, if you know that statewide, the Arizona ash line has a success rate of X%, are those that you're referring to the quit line quitting at higher or lower rates? Are there changes that can be made to your referral protocols that can improve those figures? Set both short and long-term goals. For example, if you know that you are currently advising 75% of the clients that you screen, you may be able to make small changes early to move that figure to 85% in the first year and 90% by the end of year 2. A long-term goal and a reach goal are different. A reach goal may be something like, we will work very hard to get 90% of our staff trained in how to run groups. But the reality is that most likely you will get 80%. And if you hit that number, you will consider yourself successful. A reach goal should still be achievable, but they're used for inspiration at the beginning of a planning process and not for critical review at the end of it. Finally, be honest with your benchmarks and why you did or didn't hit them. As long as you moved in the right direction, or if you're confident you know why you didn't, it's still a success. The point of collecting data is not just so that we have it. Just as I headlined the last slide, as compared to what? As the fundamental notion of where our first benchmarks come from, we want to put all of our statistics into some context, compare them across clinics, across providers, between cities, across time. And here again, not just for fun, but in order to decipher meaning from the data and to determine actions from the meaning that we find. We're likely to get this wrong a lot, but that's okay. As long as our process is thorough and honest, we'll likely to continue to make progress over time, even if we miss the mark a bit when we're trying to pinpoint causality. Some important questions to consider are, is this number higher or lower than previous years? Is the improvement or decline attributable to choices that we made or to shifts outside of our organization? Are successes replicable? And when numbers are low or if trends are going the wrong way, is that a fixable issue? Can it be solved through systemic fixes like additional training, or is this a personnel problem? As you're thinking of new processes, there are two tendencies, both of which should be avoided. One is to collect no data at all, to assume that since the intent of the change is well-meaning, that the end result will be good enough, even if it's below expectations. The other is to collect a lot of data simply because once you're in the process of collecting some new things, you may as well collect everything. If you combine this slide and the last one together, an important piece of advice can be extracted. Determine in advance how you will know whether or not your program has been successful. Then collect whatever data you can that will quantify that specific success. Ask yourself, if on this date a year from now, this number is X, what will that tell me? What directions will that give me? If you don't know the answer to that question, you might reconsider collecting that particular data point. So here's the to-do list that I promised. I'm not going to go through it because that's literally what I just spent the last 45 minutes doing. So I don't have another 45 minutes to go over this list again, but it will be on the PDF of the slide deck if you want to peruse it again in more detail. Now I want to just briefly talk about some resources that may be able to help. Eagle-eyed observers, those with rapid improvement experience and or those who simply enjoy diving into the rapid improvement literature, may have noticed that the 4-section title of this webinar were planning, doing, and study and act. The webinar was structured around the Deming cycle, also known as PDSA, and sometimes PDCA, where study is replaced with the word check. PDSA is a user-friendly program improvement process with a long history of success in the healthcare delivery field. You don't have to choose this one to structure your activities, but we like it. The best program improvement tool or process is the one you'll stick to, but I do recommend using one. If you are interested in using a rapid improvement process like PDSA, pictured here to the right is a form that we developed called the Dimensions Action Plan, which you can download off our site. It will, for free again, it will ask you to set 2 SMART goals, a way of measuring the accomplishment, and for a list of barriers to achieving it. One note, take a good look at the barrier you list. Are those barriers something that will require a plan of its own to overcome? And if so, then make sure that overcoming that barrier is one of your goals. For a brief summary of the evidence-based best practices for tobacco cessation, check out our Dimensions Tobacco-Free Toolkit for healthcare providers. Don't let the healthcare providers throw you off. They're sort of the same no matter who you are as a professional, because it's all about the user, as well as we also have several supplements on our website for different priority populations: youth, young adults, low SES, criminal justice system involved, and others. A lot of the information that I pulled for this presentation comes from this guide here, a patient-centered tobacco cessation workflow, again, for healthcare clinics. Don't let that throw you off. Site of engagement rarely makes gigantic differences beyond the type of advice this toolkit offers. Combine that with the tobacco-free policy toolkit and you're sort of off and running. And then finally, be sure to check out the website for the National Behavioral Health Network for Tobacco and Cancer Control. NVHN hosts a lot of webinars and produces resources throughout the year to help organizations deliver tobacco cessation services to their clients. Just as one example, BHWP will be presenting next month on quit lines in the behavioral health population. So if that is something that interests you, be sure to look out for that. I'm sure that either myself or Chad will be sending an email to let everybody know that that's happening once we have confirmed our date and registration link and all that good stuff. So that's it for me. So I'd like to just go ahead and open it up for questions. As discussed previously, if you missed it, you can chat those in. I am now looking at the chat line, and or you can use the Q&A box, or you can raise your hand and I will unmute your line and let you ask your question directly.